Right, hello everyone. This is us live again from Mind the Bleep. I can see that there's a good number of people here at the moment, but I'm just going to give it another 5 minutes just to allow enough people to join. So we'll be starting at 8:05 UK time. Right, okay, so I think we'll go ahead and start. So thank you everyone for joining us again. This is one of the urology series sessions under Mind the Bleep. And today's topic is going to be covering lower urinary tract symptoms. So I'm going to hand over to Antoni just now, who's going to be discussing the topic with you all today.
Thank you very much. Thanks, Zach. Can everyone hear me okay? And can you see my slides? Is that a yes?
Yeah, that's fine.
Okay. Hello, everyone. My name is Antoni. I'm an FY2 doctor in Leeds, and thank you so much for joining us today. I'd just like to take a few moments to tell you about lower urinary tract symptoms. Feel free to ask any questions throughout the presentation. Just write them down in the comment box, and then Zach will pass them over to me. I'm happy to stop the presentation to answer any questions you might have. So let's start off with the case. A 75-year-old man attends your clinic and describes a 2-month history of urinary frequency, hesitancy, nocturia, poor flow, and dribbling. What term would you use to describe his symptoms? And we've got prostatism, high pressure chronic urinary retention, BPE, BPH, and lower urinary tract symptoms. Feel free to answer in the comment box. And I'll give you a hint. This is not a trick question.
Perfect. So if you guys just pop the answers in the chat box and I'll relay those to Antoni. Great. Okay. So we're getting a lot of E's.
And that's the correct answer. So lower urinary tract symptoms is a term to describe a few types of symptoms that are related to the inability of the bladder to either store urine or void it properly. It can occur in both men and women, and in men, the greater the age, the greater the incidence of them. They are most commonly in men related to benign prostatic hyperplasia. But they can occur in women as well, especially women over the age of 40, and they are usually caused by UTIs. Now, it is important to remember that whenever you hear the term lower urinary tract symptoms, you don't immediately think of the prostate and an enlarged prostate causing them, because they can be caused by pathology of the prostate, as well as the bladder, urethra, or other pelvic organs. And sometimes even neurological disease, especially conditions that are affecting nerves that innervate the bladder. But they can be also spinal cord lesions, MS, and things like that. But we'll get into that in a moment. So whenever you are taking a history from a patient with such symptoms, it's important to distinguish between the two main types of lower urinary tract symptoms: storage and voiding symptoms. And the way to wrap your head around them is essentially storage symptoms are symptoms that show when the bladder can't keep the urine in. For instance, frequency, instead of storing the urine, the bladder keeps voiding. Nocturia, which is voiding at night. Urgency, when you're unable to store urine long enough and keep having to go to the bathroom. Or incontinence, when the bladder is just unable to store the urine voluntarily and voids without the patient's control. When you think about voiding symptoms, that's mainly symptoms related to the inability of the patient to expel urine. Things like hesitancy, intermittency, so starting and stopping of the stream, straining, terminal dribbling, and incomplete emptying, and essentially a sensation of incomplete emptying. And things that can make these symptoms worse are often caffeine use, excess alcohol, or drinking plenty of fluids before going to bed. So we can distinguish between the different types of causes of lower urinary tract symptoms in males and females. In males, like I've said, benign prostatic hyperplasia is by far the most common cause. They can be also caused by chronic prostatitis or a UTI. And in females, it's most commonly caused by, they are most commonly caused by UTIs, but sometimes can be a sign of menopause or a side effect rather of menopause. But things like malignancy of the bladder or prostate, weakness of the detrusor muscle or its instability, and that's the muscle that controls contraction of the bladder when voiding, urethral strictures or external compression from a tumor in the surrounding area, or a fecal, there's a mistake in the slide, it should be a pelvic tumor or fecal impaction, I apologize. Or sometimes, like I said, neurological conditions like spinal cord lesions or injury to the spinal cord or MS. These are common to both males and females. So that's one of the reasons why the old terms for LUTS, which was prostatism, has been abandoned, just because clinicians should not tend to think about the prostate immediately when they encounter these. There's a range of symptoms, a range of conditions that can cause them, and that's essentially the main take-home message from this slide. So going on to our second case, we have a 63-year-old man that comes in with urinary frequency and urgency, but also some pain in his lower abdomen for the last 4 months. You do a urine dipstick and you find that it's positive for blood, but he has never noticed any blood in his urine. So meaning that he's never had any frank hematuria. So what's the likely diagnosis in this case?
Okay, I'll just give it a second. You guys want to pop some answers in the box? Okay, we got an E, we got a B, getting some C's.
Okay. The correct answer is B. This is a very classic, almost MCQ style question in which bladder carcinoma in situ is the correct answer. It is a type of cancer of the bladder which is very small. However, it can grow very rapidly and is one of the most, if not the most aggressive type of bladder cancer. So it's important not, like I said, to think about the prostate always when you have these symptoms. And the thing here that gives it away is the pain, the suprapubic pain coming from the bladder, and also hematuria on the dipstick, which suggests that the cancer is leaking, the carcinoma is leaking blood into the urine. So it's quite an important case that is associated with LUTS, but isn't related to the prostate. Whenever you have a patient with such symptoms, it's important to take a good history and examine them properly. When asking them about the sort of symptoms that they've been having, it's important to elicit all the voiding and storage symptoms. You should know, you should ask about how long these have been going on for. Have they changed in the last few months or days? Is there a particular time of day that they are affected by these symptoms the most? Do they have any coping strategies? Have they tried anything? Has anything helped? Have they seen anyone in the past about it? It's important also to evaluate the effect of these symptoms on the patient's quality of life. And one of the ways we can do that is to use the International Prostate Symptom Score, which I'll go into a little bit of detail in a moment. We should screen for associated features such as hematuria. The second case illustrated that quite well. Ask for suprapubic pain or perhaps colicky pain, which could be an indication of a bladder stone or a kidney stone. It's important to ask for past medical history, listed whether the patient uses caffeine or excessive or large amounts of alcohol, and whether they've had any urological encounters in the past, either in clinic or maybe they've had some surgeries or investigations performed. Importantly, medications such as anticholinergics and antihistamines and bronchodilators can exacerbate these symptoms. So it's important to keep an eye out for these in a medication history. And then there are three main examinations that are key really in these situations. And that's an abdominal examination, allowing you to rule out a suprapubic swelling, which could be an enlarged and full bladder, which would be dull to percuss. You should examine the external genitalia to look for any abnormalities, anything unusual. And is important, especially in men, to perform a digital rectal examination, which gives you a good idea of the size of the prostate and can also hint at the pathology causing the symptoms. And we'll get into that in a little bit later.
Sorry, Anthony, I was just going to interrupt you there.
Yeah.
So we have a question from Rhiannon McLeod about the question that we had up. If you could just put that back up.
Yeah.
So they were asking, why is transitional cell carcinoma less likely than carcinoma in situ?
That's a really good question. I believe that the transitional cell carcinoma doesn't often manifest with suprapubic pain. I'm not 100% sure, but carcinoma in situ is the most likely one to be related with specifically suprapubic pain and hematuria.
That's great. Okay, thank you.
So the International Prostate Symptom Score is a tool that we can use to assess the impact of lower urinary tract symptoms on the quality of lives of patients. On the right-hand side, you can see the scoring system. It's essentially a set of questions, and patients are asked to give a score from 0 to 5. And you count up the points, and then the sum of the points gives you an idea whether the symptoms are mild, moderate, or severe. There was a systematic review, however, that came out a couple of years ago that said that this scoring system alone is not good enough to diagnose bladder outlet obstruction. So meaning that just because you score highly doesn't mean that necessarily this is a bladder outlet obstruction. And that's because there are all these conditions that we mentioned that could be causing them. However, it's a really good tool to assess quality of life on patients. And also with progression of the disease causing these symptoms and management initiated, you can perform the score multiple times to assess if there's any change, if there's improvement or worsening, or the situation hasn't changed at all. So how to investigate a patient with such symptoms? You should do a full set of bloods, especially including a full blood count, which could hint at a luring infection if the white cells are raised. Urinase are important to rule out an AKI. For instance, an enlarged prostate could be a cause of a post-renal AKI. And it could be useful to perform a prostate-specific antigen test, importantly prior to DRE, because this examination can elevate these levels of the PSA. You should dip the urine just to rule out some other causes of these symptoms. Hematuria would suggest maybe there's a bladder cancer or a stone. Nitrates and leukocytes would suggest a urinase. And then if there's glucose, perhaps the patient's got diabetes that you don't know of. And sometimes, in fact, diabetes can mimic symptoms of lower urinary tract symptoms. Things like nocturia can be a sign of diabetes. The urine should be sent for a culture, and it's important to do a post-void residual volume scan, which is essentially a bladder scan after the patient's been asked to pass urine. You can do a flow rate, which is quite a specific specialist test that you wouldn't usually do on the ward. It would probably, the patient would have to go down to the urology department. But these two examinations, the PVRV and the flow rate, can give you a good example of what's going on. If the patient's having these symptoms, but they've got a low post-void residual volume, so they manage to void the bladder entirely, maybe they've got something like an overactive bladder, and there's nothing really wrong with the outlet. But if the post-void volume is high and the flow rate is poor, maybe there's something obstructive in the way that's causing the urine not to void properly, like BPH. And then depending on what you find, you might consider an ultrasound, a CT, or an MRI, for instance, if you're suspecting a spinal cord lesion or MS. And then these specialist investigations, you wouldn't usually encounter them, like I say, on the ward. It's something you might observe if you're doing a rotational placement with the urology team. So at the top, in the top picture, you can see an example of urodynamic studies, which is essentially a test in which water is pumped into the bladder to inflate it. And then multiple sensors measure its ability to stretch and then eventually void the urine out. And you can learn things like what the flow rate is, what the pressure of the detrusor muscle is, and what the storage capacity of the bladder is. A urologist might consider doing a flexible cystoscopy, which is a test in which you pass a very thin camera up the urethra. And you can see an image from a flexible cystoscopy in the image below. So on the left-hand side, image A, that is a normal prostatic urethra just on the border looking up into the bladder, the border between the urethra and the bladder. And you can see quite a nice lumen just around this internal urethral sphincter opening. Whereas on the right-hand side, that lumen is completely obscured by the enlarged prostate lobes coming into the view from laterally on both sides. And if you're suspecting that the patient might be in chronic retention or hematuria, or has got recurrent infections, you might consider some extra imaging like a CT or an ultrasound. So once you've established the cause, there are different options for management of these patients. You can opt for a conservative regimen of management first by encouraging to regulate fluid intake, perhaps reducing intake of fluids before bedtime. If patients have got voiding symptoms, so these are these symptoms, difficulty getting the urine out, a urethral milking technique might be useful, especially in patients that have got post-micturition dribble, or double voiding, where patients are asked to void twice in quick succession. Pelvic floor exercises can be useful, and also there are other bladder training techniques like timed voiding or prompt voiding. You might opt for some medications such as anticholinergics. The first line medications are usually oxybutynin and tolterodine, which help relax the detrusor muscle. You have to be mindful they have quite a few side effects, such as dryness and essentially a lot of these typical anticholinergic side effects, and they are contraindicated in a few situations. So it's always good to look at the BNF before you prescribe them. An alternative is mirabegron, which is a beta-3 adrenergic agonist. It's got a safer side effect profile and has got less contraindications. So that's another alternative. You can also use alpha blockers such as tamsulosin. You may have encountered that on the wards. It is medication to manage symptoms mainly by relaxing the muscles of the proximal urethra. And then you've also got finasteride, which is an 5-alpha reductase inhibitor. Essentially, it works to reduce the size of the prostate, but it takes a little bit longer to work. You might consider some loop diuretics or desmopressin. There is some evidence suggesting that it might reduce nocturia in some patients. And essentially, it's important to identify the cause and then treat it. And that usually would be, it would warrant a referral to the urology team to guide this form of management. Whether the patient needs a cystoscopy, a rigid cystoscopy to remove a bladder tumor, or if the cause is prostatic, does the prostate have to be removed, or maybe just decreased in size with a TURP, which is a transurethral resection of the prostate. If you're ever unsure, just speak to the urology team. If left untreated, the urine can be stored excessively in the bladder. This inability to void can cause it to be stagnating, and that can cause UTIs or bladder calculi, which can be seen in the image on the top. If the patient has got chronic obstruction, the bladder wall may become thicker and distend, and also that might lead to overflow incontinence, which is essentially when the patient's bladder has filled in so much that the pressure inside the bladder just causes the urine to rush out without any voluntary control of the patient. And obviously, any obstructive causes of these symptoms can lead to an obstruction at the renal level and cause renal hydronephrosis, as seen in the picture on the bottom, or renal failure eventually from the high pressure. And sometimes in progressive BPH, so quite quickly developing, patients might present with acute urinary retention, and then it's important to catheterize them. Are there any questions, Zach, so far?
I'll just have a look. Does anyone have any questions so far that they'd like to put in the box? Maybe just give a couple of minutes for them to type in. Well,
if anyone has any questions, feel free to type, and then
yeah, that's fine.
You can stop me, Zach, I guess, if anything comes up. So the third case is an 82-year-old man that's been suffering from bedwetting for the past 3 months. And you examine his abdomen and find that he's got this tense, non-tender mass just above his pubic symphysis. What do you suspect is the diagnosis?
Right, so while you guys type in the answers, I'll just mention a question actually that just popped up. So yeah. Someone's asked, would you start tamsulosin and finasteride at the same time?
You can do, you absolutely can do. And we'll get into that closer to the end of the presentation. I've got a few slides about that. Essentially, they work in different ways. You might, if you feel that the patient might benefit from immediate relief of symptoms because their symptoms have been so bad, you might consider tamsulosin, which acts within a few days and relaxes some of the muscles in the pelvic region that contain alpha receptors, and you might get resolution of symptoms or improvement within a few days. Finasteride takes a little bit longer. It takes about 6 months to act, and you might consider it in patients, for instance, that you've examined, you feel that they've got a bigger prostate. Their symptoms are not terrible, but it would be good to eventually get this prostate to reduce in size. But I don't believe there's any contraindication to start them at the same time, and you see them commonly on the wards being prescribed at the same time.
That's great. Okay, I hope that was insightful for whoever asked that question. So with regards to the case, we've got one person answered B, and then the majority have answered B for this question.
Good. Yeah, that's correct. So it is high pressure, chronic urinary retention. This gentleman has clearly been having symptoms, perhaps not maybe lower urinary tract symptoms were not so bad for him, but he's definitely had some form of obstruction for quite some time, and his bladder is just constantly filled with urine. And then at night, when his muscles relax, then unfortunately this bedwetting occurs. And often, if you see these patients, that you will be able to feel their bladder very easily on examination, but it won't be tender. And you might place a catheter to drain the urine, and sometimes you can drain up to 2 liters of urine from these bladders. So the most common cause, like we said, of lower urinary tract symptoms is a benign prostatic hyperplasia, which is in fact also the most common cause of benign prostatic enlargement and bladder outflow obstruction. So lots of terms, but let's try to untangle some of them. So BPH is a histological diagnosis. You have to take a sample of the prostate, look at it under a microscope, or have the histologist look at it. And it's a form of non-cancerous hyperplasia of the glandular epithelial and stromal tissue of the prostate. Most importantly, it's non-cancerous. It's just overgrowth of the prostate. It happens in all men. It's estimated that 90% of men over 80 have BPH. BPE is, by the way, just a large prostate, regardless of the cause. And a bladder outflow obstruction is something causing the bladder to struggle with voiding, regardless of the cause. So the pathophysiology of BPH is that testosterone is converted to dihydrotestosterone, which is the more active version, by an enzyme called 5-alpha reductase, which is the enzyme that's being inhibited by finasteride. And that DTH constitutes as about 90% of androgens in the prostatic tissue, and eventually stimulates the prostatic tissue to swell with age. Risk factors include, like I said, age, but also family history, especially having a first-degree relative that has had BPH that makes you more prone to it. And men of African or Caribbean ethnicity are more likely than Caucasian men or Asian men to have BPH. Obesity is also a factor. And if you examine this prostate on a digital rectal examination, it will be enlarged, but it will be smooth, usually firm, but it will be symmetrical. And you can use finger widths to indicate enlargement. More than 2 suggests that. So a workup of the patient is very similar as previously. You do the DRE, you can encourage the patient to do a bladder diary, which is essentially just them writing down every time they've passed urine, what time it happened, were there any problems, how much did they pass, it's essentially a diary. You can dip the urine, do a post-void residual volume. So you can consider it's a good idea to do a prostate-specific antigen, and ideally before doing the DRE, like we mentioned. And then you might consider an ultrasound, and sometimes you might be able to see the prostate on ultrasound, and enlargement is classified as a prostate greater than 30 mils. And then you might refer patients to urodynamic studies, which are the tests that we mentioned previously in the specialist section. If the patient has no symptoms, you just watch and wait and reassess every now and then. You should review the medications and encourage to have a diary. And then you might offer lifestyle advice. Like we said, obesity is a risk factor. And here's that slide I was speaking about. You might consider tamsulosin. About 30 to 40% of patients will respond by having some form of having the symptoms improve within a few days. And then finasteride takes much longer, but eventually helps the prostate shrink. And then if indicated, you might consider options of removing the prostate or shrinking it in size. For instance, a TURP or a HOLEP, which is another form of ablation of the prostate. Just as an interesting point, TURP, which is this procedure you can see on the right-hand side, essentially a rigid cystoscope is passed into the urethra. And at the end of it, you can see, I don't know if you might be able to see if I use a laser pointer. Just over here, you might see a tip of the urethroskop, of the cystoscope, which essentially heats up to a very high temperature, and the urologist is able to scrape out the prostate from the inside and cause the flow to be better. Complications of that are quite commonly UTIs. Patients come back after a few days with really bad dysuria or deranged inflammatory markers, and sometimes even sepsis or septic symptoms. And then just for anyone interested in surgery, this sometimes comes up in questions, something called TURP syndrome. It's not very common nowadays. It used to be more common in the past when hyperosmolar fluid was used for irrigation of the prostate during the procedure. And then this hyperosmolar fluid would leak into the exposed venous beds and cause a hyponatremia, and patients would essentially present after the procedure with would develop symptoms of hyponatremia. So they would become confused or nauseous, they might be agitated or have some visual symptoms. Management is essentially just managing the fluid overload and careful treatment of the hyponatremia, making sure that you don't correct it too quickly. But like I said, it's not very common nowadays because saline or other irrigation can be used thanks to the invention and use of bipolar. And just the last few slides about prostate cancer, which is the most common cancer in males in the UK, accounting to about 26%. And it is estimated that 80% of men with it will survive over 10 years from diagnosis. Similar to BPH, it can be stimulated by the dihydrotestosterone. 95% of all cancers, of all prostate cancers, are adenocarcinomas, and 75% of those arise in the peripheral zone, and then some of them in transitional and central zone. It's important to remember that it's the peripheral zone, and I'll show in the next slide why. The peripheral zone it being the most common region for that occurrence. The two main types are acinar and ductal adenocarcinomas. Acinar coming from the glandular cells, they're more common, and ductal coming from the ducts. They grow faster and metastasize more commonly. Similar risk factors to BPH: age, of course, ethnicity. African and Afro-Caribbean men essentially are almost twice as likely to get prostate cancer than Caucasians. And family history plays a part, especially the BRCA1 and BRCA2 genes. Obesity, diabetes, smoking, and exercise, common side effects, common risk factors for a multiple range of other cancers as well. And then this picture on the right-hand side just illustrates the point from the previous slide. We've got a sagittal cross-section here of the pelvic organs. So the left side of the picture is anterior, the right side is posterior, and then the bladder sits superiorly over the prostate, and the urethra in this image is inferiorly. And you can see this green zone being the peripheral zone, which is located towards the kind of posterior inferior side of the prostate. And that's important because if you perform a digital rectal examination, you might be able to palpate some of the cancers. Allegedly, tumors greater than 0.2 mils can be palpable. And you might feel a irregularity in the prostate. Any sort of hard asymmetry should raise your suspicions as to the cause might be that the cause might be prostate cancer. Sometimes you might hear a description of a prostate with cancer as craggy. And actually, they are very, very often hard to feel. They are extremely hard. And if you compare it with BPH, the difference is massive on this examination. And then in terms of PSA, it's a useful investigation for monitoring of prostate cancer. A raised PSA could indicate that there is a underlying prostatic cancer somewhere in there, but it's not very specific, as if someone has had a recent DRE or does lots of exercise, such as, for instance, bike riding, has got maybe prostatitis, or has ejaculated recently, the PSA might be elevated. And it's important, it's a useful investigations to monitor as well the progress of the cancer. Patients who have received treatment for it might come back for PSAs at a later date to see if there's been any change. And then if a patient is suspected to have cancer, a biopsy would be taken. The most common one being a transperineal biopsy, being a series of biopsies taken from the majority of the prostate in a very unified and systematic manner. And that is done under a general anesthetic, but is quite safe in terms of risks of infection after the procedure. And it is now more common than a transrectal ultrasound-guided biopsy, which used to be the gold standard in the past. It was performed a local anesthetic with the help of an ultrasound probe, which was placed inside the rectum. However, because obviously you're taking samples with multiple needles that pass through the rectum into the prostate, there was quite a high risk of infection and sepsis. And these biopsies will allow the histologist to have a look at the tissues under their microscope and give the tissues a Gleason score, which is very important in stratification of patients and prediction of outcome. Essentially, on the right-hand side of the top, you can see the various ways and grades in which these prostatic cells can be differentiated. The more differentiated, the higher the grade. And the histologist will have a look at the slide. We'll find the most commonly represented grade and the second most common represented grade and give a score. So a patient that's got most commonly grade 3 cells and then some grade 4 will have a score of 3 plus 4, which equates to 7. But a patient that might have only grade 5 cells might have a 5 plus 5 score, which is incidentally the highest score. And that the prognosis then is poorer. And you can use the Gleason score in conjunction with levels of the PSA and the tumor node metastasis method of assessment of cancers to evaluate prognosis and risk of recurrence. And the table on the right-hand side at the bottom kind of gives an idea of what the level of risk is given the outcomes of the other investigations. So if somebody has got low risk because their PSA is low and their Gleason score is 3 plus 3, for instance, you might just offer active surveillance. The patient would come in for a blood test every 3 months to measure their PSA. And then every 6 months to a year, they might have a examination of the prostate, and a biopsy might be offered every 1 to 3 years. If on these investigations, these monitoring investigations, there is some evidence of progression of the cancer, radical treatment might be offered. And then that's radical treatment it must be discussed in patients that have had intermediate or high risk disease diagnosed. The most common treatment being a radical prostatectomy, which is removal of the prostate, the seminal vesicles, the surrounding tissues around the prostate, and sometimes you might also consider removal of the lymph nodes around the area. And that can be done as a robotic case or as a laparoscopic case, very rarely as an open case. Radiotherapy and brachytherapy also plays a role. Brachytherapy is essentially the specialist method in which these tiny beads that I believe are radioactive are inserted inside the prostate, and then they just emit, I believe, radiation around the area to eradicate the disease. Patients with metastatic disease would be offered chemotherapy on top of the radical prostatectomy treatment, or sometimes they might have anti-hormonal agents. And then patients that have had the full set of radical treatments, but there is evidence that their disease come back. The specialist medications such as docetaxel and cabazitaxel, or even corticosteroids, might be offered. So that's it. That's my last slide. Thank you for attending and joining in our session. Does anybody have any questions?
Thank you very much, Antoni. I'm just having a quick look through the box here. I think there was one question that I didn't pass on to you just until the end of the session. So it was actually about the question that we asked last. If you could maybe go back to that slide.
Yeah. Oops, sorry.
And in the meantime, if anyone else does have any questions, please pop them in the box, and I'll relay those to Antoni once we're done with this one. Yeah, so this is the question. Dean O'Connor has just asked, how do we differentiate between B and E?
Okay. Excellent question, Dean. You would not be able to diagnose a diverticulum very easily, other than through a flexible cystoscopy, I believe. So bladder diverticula are essentially these small outpouchings of the bladder caused by high pressure inside the bladder. And they wouldn't cause these symptoms, but these diverticula very rarely, I believe, are so huge to cause a suprapubic mass. I believe that most of these are found incidentally on a flexible cystoscopy, which is just a very small thin camera passed into the bladder to have a look. And then you might have a look inside the bladder. You might see a small diverticulum or a couple on the other side. But treatment is just, you don't treat them usually unless there are any complications. You don't really do anything about them. So it's, in this question, it's a little bit of a red herring. You wouldn't really see, unless it's some very specialized urology that is way above my head. You wouldn't really see a patient in, I don't know, the wards of A&E that you examine and you might think, oh, this is a classic bladder diverticulum.
Right, okay.
Is that all right? Is that an okay answer?
Yeah, so Dean says thank you. That sounds good. Thank you very much. I don't think there are any other questions just now, so I think we'll probably just move on to the last slide. Perfect. So thank you very much again, everyone, and thank you, Antoni, for the great presentation. Obviously, we really appreciate everyone's feedback that we've gotten so far in the series, and we're hoping that you guys can continue to do so. So please feel free to go ahead and use the QR code provided in this slide. And that will take you to the feedback form, which you can fill out, and that will give you a certificate as well for your portfolios. If you do happen to remember any other questions later on, feel free to email at the address provided for urology, and we'll be happy to get a response sent across to you guys as soon as possible. And I'm going to copy the link for the feedback form into the chat box as well, just in case the QR code isn't working for you guys for some reason. So thank you again, and be sure to join us next time. Our next session is going to be the one before the last of the series, and it's going to be on urinary incontinence. So hopefully it should be quite interesting. So thank you, everyone, and have a good night and happy new year as well. All right. Thank you.